here tonight to the Children's Medical Center, Specialty Care Center at Southlake CME series. We actually have a very special presentation for you all tonight. Dr. Shane Miller is here, and so by way of introduction, after Dr. Miller completed his education and residency at Baylor College of Medicine, he actually did a fellowship at the University of Colorado Health Science Center, and then he moved back to Dallas and joined the University of Texas Southwestern Medical Center as an assistant professor of pediatrics. Specifically, Dr. Miller joined the Division of Orthopedics to complement and assist in developing a more comprehensive sports medicine center program to take care of young and developing athletes. Dr. Miller's practice is primarily at our Legacy campus in Plano, but he's currently championing a sports medicine clinic here at Southlake, where he sees patients several times each month. Dr. Miller is actually a trained pediatrician, and so he has a passion, a specialty for educating and speaking to other pediatricians and family practitioners about concussion management, so that you'll have a resource in Dr. Miller and some information on managing and recognizing those symptoms in your own practices. So with no further ado, I give you Dr. Shane Miller.
Thank you. Do I need a microphone, or can you guys, am I mic'd on that? Is that?
Yeah, I'm recording it too.
Okay. Can you guys hear me okay if I sort of talk like this? Okay, good. I'm going to try to get through a lot of material. If there's something that I'm going too fast, or if there's a question that you need, feel free to raise a hand. Otherwise, I'll try to save some time at the end for questions and answers. Again, this talk is more for you guys than it is for me, so if there's something that I didn't touch on, please feel free, and we'll get on to that. Just sort of a show of hands. Pediatricians, okay, PAs, nurse practitioners, right? Family medicine, internal medicine, ER, anything else? Did I miss anybody else? Okay, so mostly primary care providers in the community, it looks like. That's great, that's perfect. So that's sort of how this talk is directed. Commercial, we do not have a concussion be gone machine just yet, but that will be very nice when we finally do. Our objectives tonight are to define concussion, review the signs and symptoms of a concussion, discuss the evaluation and management of a sports-related concussion, and we're going to talk about the new law that's just been passed in Texas and how that's going to affect not just pediatricians, but all of you guys that are here tonight. Unfortunately for me, I do not have any financial relationships or disclosures. There may be one or two off-label uses, but I'll mention that if I point it out. So our first case, we're going to be, I know most of you guys may not provide coverage on site, but this is a good case for us to start with. Let's see if I can get to it here. So, yeah.
Okay?
I'm fine, let's go.
Hold on, where are you?
I'm in New York.
Who am I?
Hey, Coach.
And who are you?
I'm Batman.
Sit down.
You don't understand, I'm Batman.
I do.
Not going anywhere for a while? Grab a Snickers.
Hello, Goodston. My name's Batman. You could be my assistant. Would you like that? Would you like to ride with Batman?
So not everybody's going to tell us to come ride with Batman, and it may not always be quite that obvious for us there. All right, moving on here. Okay, so we're going to review some epidemiology, the definition, pathophysiology, evaluation, signs and symptoms, a lot to get through. Diagnosis, management, return to play, the new House bill, and prevention. Epidemiology, there's 1.6 to 3.8 million concussions per year in the United States. It's a pretty broad range, but we think that there's a lot of underreporting as well. It's been about a 7% reported increase per year since 1988. Some of that we think is better in terms of better awareness and diagnosing of concussions. Some of that may be the changes in the sports. Athletes are a little bit bigger and changing, and the games have changed over the past 10, 20 years from now. High school sports, and per 1,000 exposures, I have them listed in order in terms of the most common sport to get an injury. And so we think about football. Everybody sort of thinks about, especially being in Texas, we're all aware that concussions occur in football quite a bit. But if you look, a close second is girls soccer. And you know, football is more than twice as often as boys soccer, but yet girls soccer is right up there with boys football. Why is that? Females have a higher incidence in the same sports, in girls and boys soccer, than the boys do, and there's a couple of different thoughts on that. One of them is we think that females may be a little bit more open and honest and may actually be reporting symptoms and injuries more so than the boys, and the boys try to hide it. Some of it may be in terms of strength of the cervical musculature and coordination and ability to sort of protect themselves when they get hit. And some of it may be hormonal. We're not sure. We're still sort of teasing that out. But the same thing, for example, girls basketball is number 4. Well, boys basketball is below that. So each sports that are equivalent, we're seeing less. The definition of a concussion is, the sports concussion is defined as a complex pathophysiological process affecting the brain induced by traumatic biomechanical forces. All right, that's not very helpful, but that's the best definition we can come up with. And so when a patient or a family asks me, well, what is a concussion? I say a concussion is a brain injury. And I think that a lot of times people say, oh, it's just a concussion. No, it's a brain injury, and that's something very important. That's why we're here tonight, and that's why we're taking this very seriously, is because the brain is the most important organ in the body for these young and developing athletes and our young patients. And so it's not just like a knee injury or something where you can kind of try to push through it and decide when you're ready to go back. It can be caused by a direct blow to the head or the neck, or it can be caused by an impulsive force. So if they get hit in the body and that force is impulsive up to the head. Impairment of neurologic function that resolves spontaneously. This is a functional disturbance rather than a structural injury. It may or may not involve loss of consciousness. I think that's a misconception. So over 90% of athletes who have a sports-related concussion do not lose consciousness. And loss of consciousness greater than 30 seconds may be concerning to us, but brief loss of consciousness is uncommon relative to how many times this occurs, and is not the only thing you have to get to diagnose this. This is an important one. There is no abnormality on standard structural neuroimaging studies. Okay? I saw a patient today that had seen their PCP a week ago and had been told that their CAT scan was normal, they didn't have a concussion, they could go back to sports. They came and saw me today with lots of headaches and didn't understand why they were having headaches while they were still playing and having problems. And so I think that's still a misconception, not just in the public, but even in the medical community. Some is that the CAT scan diagnoses a skull fracture or a brain bleed or something else. It's not going to tell us if there's a concussion. Okay. So again, it's a functional injury, not a structural injury. That explains that. The biomechanics of a concussion is it's usually an acceleration and deceleration type injury. Our helmets and a lot of these things are designed at slowing linear forces, and so they're great at preventing skull fractures and brain bleeds. That's what they were designed to do. But they're not able to prevent the acceleration and the rapid acceleration and deceleration. We remember the coup and contra coup type forces, but a lot of times it's a rotational force. I've seen athletes that literally will get hit in their shoulder and will be spun rapidly enough. The head's never touched, but the head just spins, and that causes a concussion, rapid rotation. So it's angular and rotational acceleration is something that's very difficult to prevent with a helmet, and that's what they're trying to work on and figure that out. But there's shearing forces as well as the acceleration that goes with that. So it's important to sort of understand. I use a lot of times the analogy, an egg yolk inside a shell with the family. As a helmet, you know, the shell may be intact if you hit the egg, but if I take an egg yolk and just sort of shake it, well, that yolk inside there is now injured, but the shell may still be just fine. And so again, going back to the CT analogy and the helmets, so the brain is very soft inside there. To the best of our knowledge, we think that there is a neurometabolic cascade that sets off an abnormality within the brain that takes a period of time to recover. There's neuronal depolarization, and there's a change in the neurotransmitters. So the potassium efflux from the axons goes out, and so you lose all the potassium, and then there's an influx of calcium into the cells. And so there's actually a shift in the neurotransmitters. And so in terms of signaling, we normally remember that it travels from the axon down the dendrite onto the next cell, but the neurotransmitters are truly out of state, and so we call it a neurometabolic dysfunction or disturbance. And that takes time, and so that explains why these athletes are feeling abnormal and are not able to do what they want to do. Is it's truly a change at the chemical level that we think is going on. There may be microscopic injury as well in terms of sort of shear forces and other things, but we think it's more related to neurochemical changes. There's an impairment of the glucose metabolism. There's impairment of the cerebral blood flow. And so all of these things, until this resolves, they're not going to be able to get better. They're not going to be able to function in school as well. They're not going to be able to do what they need to do. But again, from the outside, this athlete or patient looks very normal, and that's very frustrating for them because the teachers, the coaches, the parents, everybody expect them to be back to normal, and they want to be normal. but they're not inside, and so it's a very frustrating thing. This is sort of diagramming how it takes over minutes and hours and days, some of the changes in what we're talking about. Let's see here, how I get this going. Let's see. Uh-oh.
Oregon State. They're running that crazy formation. This is passed. Johnny leaps into the end zone. Touchdown, California. His job it all right, though. He landed on his back.
And he was up. He leaped to begin with, and then ended up landing on his back.
So you can see he's posturing there,
And he has had some freak injuries over the course of his.
all right, well, I'll sort of see if I can get out of this now. And so we see these, and I put this because I think a lot of times we're not aware that, what things really look like. By the time they come into your office and see you a day or two later or 3 days later or a week later and they're still having problems, that was a football injury, but that happens on the basketball court. Cheerleaders, soccer players, we're seeing that's sort of what happens to them. They don't all posture like that. That's whether there's decorticate or decerebrate posturing, they don't always lose consciousness, but sometimes they can be very dramatic like that, and sometimes there may not be anything that obvious, but that sort of shows you. If you guys are covering events, I'm going to go through this briefly, but just like any other injury, we always think about ABCs first. If you saw that athlete like that, you're going to come up, you're going to stabilize their cervical spine, assume that there's been a C-spine injury until you can rule that out if they're altered consciousness, and that's why a lot of times you see them get transported. And so you can see he's holding the helmet there. So we always want to sort of be aware of that. Why? What other things that we're worried about besides a concussion? They could have a spinal cord injury. They can have other focal neurologic issues, skull fractures, epidural, subdural, subarachnoid hematomas. And so those we tend to move a little bit more quickly on, obviously, than a concussion. Signs and symptoms of a concussion. I think this is a fairly good table. I like to break them down into physical or somatic symptoms, cognitive symptoms, emotional symptoms, and sleep. Okay? They have to have sort of one or any of these, any combination. Just a headache by itself without any other disturbance in the cognitive function, I don't call a concussion. It depends on sort of the situation. But if they have any combination of these, they may not always have a headache. Headache is going to be the most common. And I put in red the things that I feel like probably the athletes report most to me in terms of their more common symptoms. So headache is going to be very common. A little bit of balance problems. Fatigue is extremely common, especially as the day goes on. They get very tired. So I say it's sort of like if you're running a marathon and you have an injured knee, by the end you're going to be very, very tired. It's going to hurt a lot more. Well, if they try to go to school, that's their marathon for their brain. Their brain is working hard, and we already know that there's that metabolic dysfunction. Their brain's not able to work, so they get a headache. They feel fatigued. They're irritable. Irritability is one of the things that parents complain about the most to me, and say, the kids aren't aware of it, the parents are, and it's causing a lot of tension. And so I always point it out and say, tell the little brother and sister they need to take it easy. But I also tell the patient, you need to have a little bit more patience right now, because things that upset you right now may make maybe more than normal. So you need to take it easy. And on the parents, you need to have a little bit more patience. That will get better, but irritability is very common. Other emotional symptoms as well. The feelings slow down. They feel like the world is sort of going in fast forward around them. We're not moving any differently, but they're feeling that much slower. Again, going back to what you think about, the signals are just not able to be transmitted as normally as possible, and difficulty concentrating when they go back to school. Yes, sir.
You said if they have only a headache, you don't consider that a concussion?
I think that you have to take, and we'll talk a little bit about how you make the diagnosis, but I think that if somebody comes in and they say, oh, I just have a headache, nothing else, then that's not necessarily a concussion, because we've all bumped our heads and had headaches and things like that as kids.
3 days later,
So
you still have a headache? Is that
I think it sort of depends on the context. If it's 3 days later, it's probably more going on, but that's when we start looking at other things, because I think a lot of times, especially the younger athletes, high schoolers, it's they may hide the symptoms from you, but they're able to tell you their symptoms. But when you're looking at kids 12 and under or so, they have a very hard time verbalizing symptoms. And so the headache may be the only thing that they can tell me that they're having. They may not be able to say, oh, I feel slow, or I'm having trouble concentrating. So my threshold to diagnose that or to assume that is, I'm much more conservative in younger athletes and younger patients than I am in somebody who's 16 or 17. And I can, and really talk to them and say, well, is there really nothing else going on? But But for example, a lot of the football players will come off and have a hit to their head, and or their helmet's tight or what it is, and they come up and have a headache. But if there's not anything else going on, then I won't always just call that.
So red are the most reported, but not the most significant.
That's correct. We don't know. There are some prognostic factors we're still trying to figure out. We think, for example, if somebody who's dizzy or complaining of dizziness at the time of the injury, that may be more of a prolonged recovery. Prolonged loss of consciousness, we think. Anterograde amnesia, or forgetting events prior to the event, is more prognostic. It's very common to have retrograde amnesia or forget what happened for the few minutes afterwards. But if they can't remember what they had for lunch that day before they went to basketball practice, then that may mean they have a longer recovery. Other comorbidities of things, if they have a history or personal or family history of migraines, ADHD, depression, anxiety, learning disability, those are also prognostic for probably a more complex or prolonged recovery. But in terms of which symptoms of these we think, we're still sort of teasing that out right now. And sleep is also something that's important because they got to get rest to heal, and if they can't sleep, then they can't heal. The physical signs, some of the things that we may see: poor coordination, unsteady gait, a seizure or posturing like that athlete. They may be slow to answer your questions or follow commands. I think that a lot of times these are athletes, patients that I've never met. They're patients that you've known growing up, but I've never met them, and I walk in the room and I'm usually struck by how quiet these teenagers are that are just sort of sitting there. Sometimes the lights are off. Hey, how are you feeling? I'm fine. That's not a normal teenager. They're usually flat, or if they're there and they want to be playing sports, then I'm fine, let me go back to the sports. But when they're just sort of sitting there like that, that's not normal. And I say, 2 weeks from now they come back and they look back normal. I say, that's your child, right? And they say, yeah, that's my child again. Poor concentration, behavior, personality changes, inappropriate playing behavior, running the wrong direction down the field, things like that. Our initial evaluation, I always do a complete physical examination, especially early on, if I'm on the field especially, trying to make sure that I haven't missed anything else. I'm checking the neck, I'm checking for other signs of skull fracture, I'm looking in the ears for hemotympanum, I'm looking behind the ears, I'm looking in their mouth, looking in their nose, and sort of making sure that there's not something else. If they're still altered, they may not be by the time they get to you, but if they're still altered, they may not be aware that they have a broken wrist or something else that's going on. Neurologic examination, you guys are excellent at doing, and so doing a neuro exam, but then I focus on balance and eye movements, and we'll talk a little bit about the balance testing. But eye movements is something that I will occasionally see they have a hard time with smooth pursuit, sort of following the finger, and especially if I get upward gaze, that sort of thing, that it bothers them. Sort of see their eyes flick back to the middle and they kind of blink their eyes because they don't like that. And then the balance is something that definitely you guys should be doing in the office, and we'll show you how to do that. And then a standardized assessment, sort of like a mini mental status exam, but the one that I recommend is called the Sports Concussion Assessment Tool version 2, which is the SCAT-2, and we'll go over that as well. This is available to you guys. You can get it from the children's website, the AAP, you can get it at lots of different places, and at the very end it's in the resources of how to get it. But I'm not going to spend a lot of time on this because it walks you through it step by step, literally. You can hand it to an MA and they should be able to walk through it and get a fairly similar score to what you're going to get on this, because it tells you, read word for word, these are the instructions, and then this is how you do it. But it has them fill out a symptom scale. So talking about a lot of the symptoms that we had, they rate from 0 to 6. 0 is nothing at all and 6 is severe. What do they have? And so that gives you an idea of how many symptoms they're having and how severe those symptoms are. And it's not uncommon that the first, when they first fill this out, there are many 5s and 6s, there are a few 0s, but a lot of them are very severe. And then you watch them and they slowly come down to 3 to 4 to 2 to 1, and then they finally disappear. So they start off more severe. And the more symptoms that they have, and the more severe they have, the more prolonged recovery they're going to have as well. So if somebody has a very high symptom burden or lots of symptoms, then they're more likely to take longer to recover, or if they're perceiving their symptoms as severe. Physical sciences, they get knocked out. GCS, by the time they're in your office, they're probably at a GCS of 15. This is more for watching for deterioration. If I observe them and they're 15 and then I go off shift in the ER and the next person comes in and now they have a GCS of 12, we need to scan them and look for something else besides a concussion. They shouldn't be deteriorating like that. Asking them things that athletes should know. This is when you're at the, where are we? What half is it? Who did we play last week? Did we win? And you don't necessarily have to go exactly through these, but things, you can ask your athletes. An athlete may not be able to count backwards from 100 by 7, the football players especially, but they should know who they played last week. All right, it's unfortunate but true. And so they actually took serial 7s out of this because many of our athletes were unable to do it. Orientation score, we're looking at, how oriented are they here. Immediate memory, and then we come back, we don't tell them, but we come back later and do a delayed recall. Concentration, digits backwards instead of the serial sevens, and then saying the months backwards. That's a little easier than counting backwards by 7. Are they able to get those? And again, you go through and you add all these up. This is the balance examination. I am going to pause here for a minute because this is something that I use every day, an initial visit and every follow-up visit, because balance is one of the few objective findings on exam for a concussion that improves as their brain injury recovers. And not everybody's going to have balance impairment, but the majority of them do, and then it tends to get better. Part of it is I do it enough so I know what's going to be normal for an 8-year-old versus a 10-year-old versus a 14-year-old versus a 17-year-old, but obviously a 4-year-old wouldn't be able to balance the same as a 16-year-old. But what we're doing is we're doing sort of 3 tests, and it takes about a minute and a half to go through this. And I tell them I'm going to do 3 tests. They're going to be 20 seconds each. We're going to count the number of times you sort of open your eyes or step out. It's okay if you do, just open your eyes, get set, and go back to it again. And you count the number of times they make an error, and you add that up. There's a total of 30 possible points, 30 being the best score, and then each time they mess up, they lose a point. So the first one is feet together, side by side. Have them put their hands on their hips, and that's mostly so in case they fall, you can grab their arms, they don't fall all the way to the ground. And then when they're set, then they close their eyes. And so you're taking away the visual feedback in terms of balance there. That one they tend to do fairly well on. And the next step is you say, which foot do you use to kick a ball? So, okay, my right foot. All right, I want you to lift your right foot up in the air about like this. Hands on your hips. Don't touch your feet together there. And then again, when they're steady, they close their eyes. Okay? And again, it walks you through exactly how to do this. It describes the exact perfect stance there. For 20 seconds, they stay there. This is the most difficult of the 3 tests because you're standing on 1 foot. Then the third. Sure. So you're just basically standing on 1 foot, hands on your hips, sort of like a, I don't know, Karate Kid or crane, and just sort of standing there and then close the eyes. Sure. And then the third one is a tandem gait, and you have your dominant foot in front, toe to heel, just side to side like that. Again, hands on the hips, and then when they're steady, they close their eyes. And so normal for our high schoolers is probably 27 to 30. They're allowed to make a couple of mistakes. It's not easy. If you guys try it at home tonight, it's not easy, especially the one leg stance with your eyes closed. They may make a mistake or 2, but when they're making 5, 6, 7 mistakes, especially in their, the middle schoolers and high schoolers, that's not usually normal. You can sort of look at them and determine some people may not have as good a balance as others, but in general, and then it improves as they recover. So that's something that I look at every visit. Coordination, this is part of your neuro exam, finger, nose, finger, looking at cerebellar. And now we've come back, we're asking the words again for the delayed recall. And then you add it all up and you can give them a score. And then this is helpful for you guys without having to have computerized testing and all these other things. This is a fairly basic exam to do. If there's an MA or a nurse that feels comfortable doing this, they can do it and then come out of the room and hand you this and say, hey, we went through and this is their scores. And you can also, again, show them, as they improve. And it gives you different words. You don't want to give them the same words each time if you do it again. But if they can do fairly well on a lot of this, I think that you're concerned about something else going on. I think sometimes you guys are trying to decide, do I need to send them to the ER or not? But if they're able to do quite a bit of this and do fairly well, then they're probably concussed, but they probably don't have a brain bleed or something else going on. I'm going to skip over this in the interest of time. 14-year-old lacrosse player suffers a brief loss of consciousness. And during a playoff game, it's very important to him. Gets up immediately, gets back into the position. Neither the trainer or the doctor are out there. He just sort of yells, I'm fine, let's go. So can he keep playing, and why is he out there? And why do they not want us to know that they're injured? And so they did a study, this is in 2004, and I think that it's probably similar to results now. So 2/3 of them didn't think a concussion was serious enough to report. Despite everything that we've learned and everything we hear in the news and all that we're aware of as pediatricians, I think that's probably accurate, that 2/3 of them, especially our high schoolers, they think they're invincible, they're teenagers. Nothing's going to hurt them, and they try to play through it. They didn't want to come out of the game. They didn't want to let their teammates down. I think it is important to realize that 1/3 of them may have a brain injury and may not be aware that they're actually injured. So I can't always blame it on them just trying to be tough. Sometimes they just are not sure that they're injured. And I saw a boy today that he went to practice and fell down, and actually I think he was heading a soccer ball. he remembers hitting the soccer ball and he remembers scoring a goal in practice. He doesn't remember Saturday or Sunday. This happened on Saturday. He doesn't remember going to church the next day. He doesn't remember anything else. And was sort of asking Mom, we went to church, right? You know, and so for him to know that he has a concussion, pull himself out of the game, that's not really his fault. So we need to be aware of those and try to pull him out. So how do we make the diagnosis? This is hard because we said it's not based on CAT scan. So it's based on the history. It's based on the signs and symptoms. It's based on your exam findings. It's based on your neurocognitive testing. It's based on your balance testing. All of that put together, that's how I come up with the decision, is this or is this not a concussion? Okay? So if somebody comes into me and they're having memory problems, confusion, a headache, and nausea, but they've been at school for the past week and haven't been playing any sports, well then they may have encephalitis or a viral illness or something else going on, not always necessarily a concussion. So it has to be in the right context. But vice versa, if somebody comes in and are complaining of some of those things, you need to ask, has there been a history of a trauma that could explain why some of these other symptoms are going on? Somebody comes in with a new onset headaches or migraines or difficulty at school or vision problems, blurry vision, ask them, did you bump your head at all in the past week or two that sort of set this off? Because sometimes they may not be aware of the inciting event. Again, neuroimaging is usually normal and not required for the diagnosis. And grading scales are no longer recommended. I think not very long ago we were using grading scales. Originally it was sort of grade 1, grade 2, grade 3 based on symptoms and how long you were knocked out. Then we went away from that and we changed into what we called simple or complex concussions. And now we've gone into just calling it what it is. It's a concussion. It's a brain injury. And well, how bad is it? We don't know until you're healed. And if it took you 8 months to get over your concussion, that was a really bad one. If it took you a week to get over it, that wasn't a very bad concussion. And so that's not always how they look when they first see you, but I think in terms of recovery. So it's hard for us to know, but we don't, one thing I would encourage you guys to be careful using is the words mild, moderate, or severe. We in the medical profession, we understand that a severe TBI is different than a concussion. Okay, our moderate, those are the kids we remember in residency that were in the ICU intubated and had very bad, these are high velocity falls from 20 feet, et cetera. So by definition, this is a mild TBI on the scale of brain injuries. However, I think that the families sometimes hear mild and concussion, put it together, and they say, oh, it's just a mild concussion. And I hear that just, and then they're thinking, my kid's fine, we can push them back, and it's nothing to worry about. And so I don't want to scare them and play, but I want them to be aware this is a brain injury. Your kid's going to be fine. I reassure them, you're going to be fine, you just need some time. But we can't overlook this. So when do we want them to get some neuroimaging? I put it up top because that's usually when it's going to happen. Worsening symptoms. Okay? Just because 5 days from their injury they're still having symptoms doesn't mean they need a CAT scan. Okay? If they're getting worse, that's a reason to do that. If they are vomiting repeatedly, I allow them to vomit once. If they vomit twice, they've bought themselves a scan for me. Very severe headache that's not responsive to our over-the-counter analgesic, so Tylenol or something. If that makes them feel better, unlikely that they have a brain bleed or something else going on. Obviously, extremely drowsy or lethargic. All of them are going to be tired and fatigued, unable to recognize people or places. Prolonged loss of consciousness. For me, that's greater than 30 seconds. Any focal neurologic deficit, they've had seizures, slurred speech, unsteady gait is a little bit blurry there because, like we talked about, their balance, all of them are going to have poor balance. But if they really can't walk very well and they're all over the place, it's reasonable to get it. Weakness, most of them should still be strong in your muscle testing. Abnormal behavior is also variable because we're talking about irritable. Well, they're all irritable. And so if I'm scanning every kid that's irritable, I think that you have to take that in context if it's extreme. Or prolonged recovery. If it's been over a month and they're still not getting better, it may be reasonable to neuroimage them. So what do we get, a CT or an MRI? Within the first 48 hours, a CT is useful to rule out an intracranial bleed or skull fracture. After 48 hours, the likelihood of them having a bleed that's significant is lower. And if it is, an MRI is going to pick it up anyway. But if it was something that's causing them worsening problems, so an MRI is recommended if it's been more than 48 hours. And I understand sometimes that's hard to get, but usually if they've made it 4 or 5 days and they're presenting in your office, they're probably stable and they can get that MRI done. Functional MRI or DTI, diffusion tensor imaging, is promising in terms of research, but we don't use that clinically, and you can't really just sort of order one of those to look for that. So again, neuroimaging is not required. We're looking for this when we're worried something else is going on. And a lot of times it's the parents that are worried, but I think us being aware that they may feel terrible for weeks, and if they're doing too much, they're going to feel worse. That's one thing I have to tell parents is worsening symptoms. But if your kid goes out and tries to mow the lawn tomorrow, he's going to feel worse. He's going to feel miserable. And he's going to come in, you're going to think your kid's regressed terribly. Well, it's because they did too much and they felt worse. Neuropsychological or neurocognitive testing. You guys have probably heard a lot about what's called the IMPACT test. IMPACT is one brand of computerized neurocognitive testing. It tests memory, reaction, concentration, reaction time, and some of the measures of things that we think are impaired with a concussion. So it's basically taking the 8-hour paper and pencil neuropsych testing that our colleagues do for ADHD and learning disabilities and these other things, narrowing it down to about a half-hour computerized test to sort of give us an idea and focuses on the things that we think are injured in terms of concussion. Again, IMPACT is one version of that. So when people say, oh, I'm here for my IMPACT test, well, you're here to get a computerized neurocognitive test, and IMPACT is a brand of that, but they've done a very good job of marketing. IMPACT is one tool that I use. I would say that probably less than 5% of the time does it change my management of a patient, other than helping me convince parents that their kid is still injured and that there's something there when they think that their kid is fine. But 95% of the time, it's clinical judgment and experience of saying your child is still not ready to go or they are ready to go. And so I don't think that we have to rely on this. This is a tool to add in with everything else that we're doing. But the balance, our exam, the symptoms, talking to the families, all of that are very important. It's best if they do what we call a baseline test, meaning they test themselves prior to their injury. So rather than me trying to compare them to every other child, we're comparing them to themselves. There are norms and standards that you can sort of use if they've been injured, but it's best if we know we can compare them to themselves 6 months ago. They should be at least as smart and as fast as they were 6 months ago before the season and before their injury. And if they're not, then they're still recovering. What is known as the Zurich Guidelines, these are a group of people got together, a bunch of the experts, and put together the guidelines in 2008 of what we think. And this is really what sort of guided our management that we're using now, as well as the new laws. And this is a shift from the you're out for a week or you're out for 2 weeks or whatever it is. So the player does not go back to play in the current game or practice. That's actually gone even up at the NFL and professional levels now. They are not allowed to go back the same day if they've had a concussion. So that's good. In our kids, we're always going to be more conservative. The younger brain is still developing and is going to take a little longer to recover. One of the things that's very important, I think, is that symptoms may evolve over several hours. Okay? So an athlete may have just a headache during the game and they think they're fine. 2 hours after the game, now they're miserable and they have photophobia, phonophobia, confusion, memory problems, they're dizzy, all of that because that neurometabolic cascade is evolving like we looked at. And so that's why now I'm much more conservative. And if I see that athlete that had a good hit, or even if they didn't, if I think at all that headache now is a concussion, then I'm going to hold them out and err on the side of conservative and be more cautious. I would always rather hold somebody out and have them not need to be out than put somebody in and have them need to be out because you can do a lot more damage by letting them go back too soon. Don't leave them alone. You monitor them over the first few hours, make sure they get worse. Yes, ma'am.
When you talk about not leaving them alone, like
yeah.
this is when I usually see them, like pretty soon after the injury. But
okay.
when you say leave them alone, like is it necessary to the old kind of things like wake them up?
No, it's a good question. So meaning they have to have a responsible somebody to watch out for them. If I have a 17-year-old senior in high school on a Friday night, I don't let him go out with his buddies that night after the game. He needs to go home. He can't go home by himself. A mom or a dad or a responsible somebody needs to be there to sort of keep an eye on. In case things get worse, they can take, be aware of it and take them in. And so it's not that we have to, put them in 24-hour obs or anything like that. But no, that's a good question. I think that I tell the parents, to check on them when they go to bed, but sleep is very important. So we want them to get uninterrupted sleep. And then, they can wake them up in the morning if they, when the parents get up to make themselves feel better. But really the athlete needs to sleep. And so I don't have them wake them up every hour. It's a good question. They need to be medically evaluated following the injury. It's nice now. That's part of the law. And they should never go back to play while symptomatic, period. And that's the answer now. It's when can you go back? Is it 1 week? Is it 2 weeks? Is it a month? Is it when they no longer have any symptoms? No longer when they have any symptoms. And we say, when in doubt, sit them out. Again, we're there to protect them, and half the time we're protecting them from themselves as well as their coaches and their parents. And that's unfortunately one of our roles now is to sort of help them, because the parents and the athletes and the coaches always think that they're ready to go back before I do. Next one, 16-year-old, sacked. He didn't tell the coach. Didn't tell anybody. He sort of, I got a little bit of headache. He sort of went back to school, went back a couple of days, didn't really get evaluated. Takes a little small hit, nothing big, didn't get knocked out, seems stunned, tries to go back to the huddle, walks off the field, collapses, dilated pupils, dies. It's called second impact syndrome. This is a very rare event, and I don't try to scare the kids and tell them this is going to happen to you, but this is something that happens only in the adolescence population. We think that it has to do with that cerebral dysautonomia or autonomic dysfunction, and there's the normal autoregulation of blood flow in and out of the skull is altered. And so when they get injured, there's edema, massive cerebral edema, they have herniation, and they can die. And if they don't die, they can have permanent neurological impairment. And so this tends to happen within the first 2 to 3 weeks of the initial injury. And it tends to be athletes who are still symptomatic. When we go back and study these cases, almost every single one of them was telling a teammate, or the teammate saw them take an Advil before the game, or whatever it was. They were still having symptoms, but they were minimizing them or hiding them or had been missed somehow. And so that's why I'm very adamant that they do not have any symptoms back to their baseline. If they'd had migraines daily, well, then that's sort of harder to figure out. But I think that most of our patients, they should be having no symptoms before they go back to play. And it may be weeks. I think that most of these people get better in a week or two, but they're not back to normal. I think that even in the high school athlete, it's probably 3 to 4 weeks before the brain is back to normal, at least what we think. Some of the pathologists say it's up to 90 days, but in terms of when they're truly asymptomatic, I think it's 3 to 4 weeks. And in a younger athlete, if they're sort of 12 and under, I'm often telling them it's going to be 4 to 6 weeks before you're back playing again from this injury. Your kid's going to tell me that they're fine, and then you're going to think they're fine, and then I'll finally tell you I think that they're fine. But that's a lot longer. Yes, sir.
Do you change your treatment if there are multiple concussions?
Yes. Yes, there are lots of modifying factors, and age is one, the number of concussions, the timing of them, how long they've taken to recover, any comorbidities like migraines, ADHD, depression, all of those things will alter our sort of standard, or our treatment a little bit. And each one of these things you're going to individualize to the patient. And so, not everybody's going to have the same brain injury, and they're all different. But so you have to take in a lot of those factors in terms of their history. So when we're concerned, going back too soon may not, not everybody's going to die, but a lot of them will go back, and it will prolong the recovery if they try to do too much. They're at risk of a second injury, and there may be neurocognitive impairment, long-term problems, depression, emotional problems, memory issues down the road. Management. This is very important for us. Rest makes it easy, but I think the families and athletes have a very hard time with this. The first 3 to 4 weeks, there's very little that I do to actively treat or manage these concussions other than educate them and have them rest. And I think that's where you guys come in, because absolutely as the PCPs, in pediatrics we spend a lot of time reassuring and educating. And that's how we take great care of the patients. But this is very important here. So it's not just physical rest. They sort of understand, okay, no sports, got it. But that means no wrestling with your brother. That means no going to Six Flags and running roller coasters. That means no PE class, no vacuuming the house, no, really, I really have them shut down and become a couch potato. So this is the one time that we, as pediatricians, are going to tell you not to do anything physically active. So that part is very important, and the more they try to do, it will prolong their recovery and it will make them feel worse. Cognitive rest, okay, and we'll talk about school in a second, but in our population, we have to think about technology. So video games, TV, texting, Facebook, internet, computer use. This will make them feel worse, make them prolong the recovery. So the first few days, I often say, none of that. Mom, take the phone away. Turn off the computer. If they have a laptop for school, they can't use their laptop. They can't get on the internet. They can't play video games. All of these things need to be taken away. So we say lights out. All these machines need to be turned off. Okay. Sleep. So we're taking everything away from them. It's very boring. So they can't play sports, they can't text, they can't go to school, all these things. It's fun. But they will get better faster and get back to normal more quickly. Sleep is very important. A normal teenager needs 9 to 10 hours of sleep per night. Very few of them get that. But a teenager with a brain injury absolutely needs to be getting that much to help them get back to normal. And so there's no reason that they have to be up till 11 o'clock. If we're taking away their homework and we're taking away their sports, well, what are they doing till 11 o'clock? They don't have anything. They need to be in bed. They need to be in bed by 8 or 9 or whenever it is. get some sleep and get up the next day. They will do better if they recover and get some sleep. This is an example of some of the academic accommodations that I may make. Early on, if they're very symptomatic, when you're seeing them, it's completely reasonable to keep them home from school for a few days or a week. At least a day or two is very reasonable, because they're going to go, their brain is not able to function even if they want to. It's going to make them feel worse. They're not going to get anything out of it. They're going to sit there and be miserable. And so they'd be better off at home resting. When they go back, they may be able to go back for a half day at first. Or they maybe go back and say, okay, well, twice during the day I want you to go take a 15-minute break and lay down, getting breaks in between the day to sort of break things up. A lot of times about halfway through the day after the lunch period, they start to fatigue, they get headaches, the noises in the cafeteria will bother them, and they sort of crash and crater. So you may say, all right, Mom, go pick them up before lunch tomorrow, see how that goes. If they do well, then they can sort of get back a little further. A lot of times I'll take away tests, homework assignments, quizzes for a week or two. They're not going to do well anyway. It's going to stress them out. If they try to study the night before, it's going to make them feel bad, and then they can't remember it. They go in there, and now they're worried they have a bad grade. The teachers are worried. It just stresses everybody out. So I say no tests. And then when they can go back, well, maybe you let them have as much time as they need. So there are lots of different things that we can accommodate and work with them. But I think it's very important to get the school involved early on. I always send a letter to the school saying this child has a concussion. Please help us work with them, because your student is going to get back a lot faster if you guys don't try to overload them. And I think as pediatricians, that's something that we can do quite a bit, is really get the school, and whether that's a school nurse or a counselor, have somebody that the parent takes the note to and says, okay, I need some help, I have a concussion. Okay? And one of the handouts that we put together for you guys is something that you can give to patients after you've said, okay, you have a concussion. I've diagnosed your child with a concussion, and there's a list of some possible academic accommodations in there that the school can make. It's, I think, the sort of the more purple one. So this, the smaller font when the purple on the bottom is one that you guys can give to the families once they've sort of been diagnosed.
Have you ever given medication to help the kids sleep?
I'm sorry?
I thought of it. Have you ever given medication?
So it depends on how far they are, but yes, melatonin I occasionally will recommend if they're having trouble sleeping, and especially some of the teenagers that are really struggling to fall asleep. I think that's a reasonable thing to do. I stay away from some of the, Ambien and Lunesta, some of the other things, because I try not to alter the chemical function of the brain too much. Yeah. For their pain, headaches are very problematic. The first 48 to 72 hours, I stick with Tylenol only, especially if I've seen them, in the field or in the ER. There is a small but theoretical increased risk of bleeding if you've taken an NSAID. So if they have a small brain bleed that we're not aware of, you give them an NSAID, they could bleed more. I don't know that it's been documented, but that's sort of the theory behind it. After about 48, 72 hours, so usually by the time they've actually made it to your office probably, I think it's completely reasonable to try Advil or Aleve. I find that naproxen tends to work fairly well because it has a little longer duration. So whereas the ibuprofen wears off after about 6 hours, so if they take it at 7 a.m. when it's wearing off right after lunch, which is when they're already starting to crash anyway, so the Aleve will last them through the day, and so that's something that they can try. And I really avoid narcotics. Narcotics do not help with these headaches. They get prescribed all the time in the ER. The kids come in. But for people who are not taking narcotics regularly, they're going to be a little woozy and altered and out of it anyway. So now we add that on top of a concussion, and it makes the parents worried, and it makes them out of it, and it doesn't help their headaches. So I would say if they're needing something stronger than an over-the-counter medication, then you may want to have them sort of checked out. But again, sleep. They just got to take it easy. These will get better. I have some pictures on here. These are off-label, but amitriptyline is something we will use for prolonged headaches. It also helps them sleep a little bit, but a tricyclic antidepressant is not something I throw on somebody initially when they've had an injury. Amantadine sometimes with their concentration. So there are some other little tricks in our bag that we will use, but probably if you're getting to the point that you think they need that, those are then the patients you want to refer on and let us help you manage rather than you guys trying to deal with that. So we'll talk about some of the reasons to refer. But so return to play. How am I doing on time? I'm sorry, I don't have. 7:15. Okay. All right, we got to get rocking and rolling here. So when can they go back to play? Again, no athlete with signs or symptoms of concussion at rest or with exertion should be allowed to go back. We do a graded progression, which we'll talk about, and you take at least 24 hours between each stage. So if it's a 5 or 6 stage progression, it's going to take them at least a week to get back. And I always tell them that from the time that you're no longer having any symptoms at all at rest, with your day-to-day stuff, with schoolwork, including taking tests, and you're back to normal cognitive function, then we'll start talking about sports. when we start talking about sports, it's going to take me at least a week to get you back. So don't come in on a Monday assuming you're going to play in the game Monday night or Tuesday. It's going to take me a week to get you back. And the younger the athlete, we may take longer than that. Or if they've had more than one concussion, we may take longer than that. If they've had a prolonged recovery. So there's lots of things that may alter that. So, but I go ahead and tell them. So if I assume it's going to be a 3-week recovery and then a week to get them back, well, you're looking at probably a month from the time of the concussion. It's not what I used to think when I was a resident. Oh, it's a week or a few days and they're going to be right back the following week. You know, some athletes will recover that quickly, but I'm not seeing most of them do. They get a lot better in a week or two, but it takes them a while to get the rest there. So we go through, and we'll show you on the next page, it's just sort of a gradual progression. So aerobic exercise, then sport-specific activities, then non-contact activity, then contact practice, then a game. So I have it broken down here by stage and the goal of each. So the first one is rest. Okay, that's the most important thing, and so they can't move on to any exercise until they don't have any symptoms. So light aerobic activity, just get their heart rate up a little bit. Sometimes, again, pumping blood to the brain is going to make them not feel well. And a lot of times it's not while they're doing it, it's 2 hours after they get done that they'll feel bad. And so they're like, oh, I'm fine, I can keep going. 10 minutes, you're done, and then we'll see how you feel tonight, we'll see how you feel tomorrow. Okay? If you felt great and didn't have any symptoms, you didn't feel lightheaded, didn't feel dizzy, didn't have headaches, then we let you go on to the next stage. Well, now we let you work out a little bit more. Then we add in head movements, then we add in hand-eye coordination and balls. Then we add in practice, and so a lot of times it just sort of takes a little bit of time, but you can't skip any steps. And so again, if they come and see me and the game's 4 days from now, sorry, you're going to miss one more game. It's better to miss one game than the whole season, but we're not going to skip steps, especially in our pediatric athletes. You know, they don't even skip steps at the professional level, and so we're certainly not going to speed this process up. It takes at least 24 hours between each stage. They have to go through that. They have to be confident. I think that's very important. A lot of times if the athlete doesn't want to be on the field, they're going to go back timid, they're going to get hurt. And so I'm very cognizant. If I feel like an athlete is sort of not ready to go, then I don't clear them. I say, look, I'm on your team. You know, you tell me when you're ready and then we'll talk about it. But until then, I'm not going to put you back out there where the coaches can make you go. Helmets we'll talk about briefly. And then again, considering implications of multiple injuries or recent injuries, that may change our return to play decision. So some of those more complex athletes, again, those are probably ones that we're happy to help consult on and help make decisions about whether or not they should go back. This is important. House Bill 2038 was actually passed in May, signed by the governor in June of this year, and implemented starting September 1st with this school year. It applies to UIL schools and any charter schools. So private schools were originally included, but they threatened to sue and were excluded from the law. But that doesn't mean that they should be managed any differently, in my opinion, because this is not, it's a new law, but it's not changing anything I just told you. Okay? All I'm going to do is basically go over now the law. So in terms of the way we're managing patients, other than the fact that now they have to get a signature from one of you guys to go back, but it doesn't change our management of the patient. Each school district has to create a concussion oversight team. Each team must include one physician, and then they can include athletic trainers, they can include PAs, neuropsychologists, anything else, but each school district in the state of Texas has to have one physician on their concussion oversight team. That doesn't mean that doctor has to clear every concussion. It just means they have to help put together sort of the management protocol for that school district. Every student now has to have education prior to the season. This is good. We're trying to educate them. And so the students and the parents must read and sign something that's saying that they've understood what a concussion is and the danger of playing the sports. And so again, we're just trying to educate them so that they're aware. When they do get injured, maybe they'll tell us. And why are we worried about this? Coaches and athletic trainers have to take every 2 years a CME course on concussion management. That's fine. I think it's good that the coaches are being educated. So this does not apply to physicians. It's encouraged that if you're taking care of concussions that you take a sort of continuing education conference, something like this. This would suffice. You don't have to do the 2-hour course. However, PAs and NPs do have to take the 2-hour course. Sorry. But in terms of the management of the patients, immediate removal from play for any athlete believed to have had a concussion. They changed the wording. The original bill said suspected of having a concussion. While the coaches were worried about bringing their players over to the sideline, saying because they felt like if anybody's even thought that they might have a concussion, that the kid couldn't go back in, even if the doctor looked at him and sent back. And so then the coaches were sort of not pulling the kids over. Well, that was a backfire. We want them to tell us if they're worried about something. And so now they changed it to believe. So if we're there and we decide, oh, you know what, he actually just got the wind knocked out of him, he's fine, he can go back, well, then that's fine. But if they have a concussion, they don't go back. Progressive return to play, we talked about that. One's completely asymptomatic. That's not anything different. This is a little bit different. They have to have a signed clearance by the physician, the student, and the parent or parent guardian prior to going back to sports. So in the past, a coach or the parent or the student themselves could decide when they felt like they were ready. And so the goal is they have to be now cleared by a physician. It's not to put liability onto us. I think it's to help take liability off of some of the athletic trainers who in the past may have felt like their students weren't ready to go back and the coaches and the parents were, and they had nothing to say in the matter. And so now at least they can say, well, you don't have a physician's signature, you have to go get that signed. And so it's not to scare you guys. You guys have been managing concussions and doing a great job at it for years. And so it's just now you have to sign to it saying that they're asymptomatic, they're back to their baseline neurocognitively, they're doing fine in school. And then the parents have to sign off and saying, yes, we followed this gradual return to play, yes, we understand what a concussion is, yes, my child's asymptomatic. So that they have to have a little bit of say in this as well and have to take some responsibility, and then the student has to sign as well. I don't think that ER or urgent care physicians should be signing these forms. And I do not think that they should be telling the athletes return to play guidelines. I feel like the pediatrician and their PCP really, their medical home is where they need to be. You guys know the athletes best, and you know they're going to try to sneak in just to get a signature in the urgent care doc in the box, and they get signed off. And I often see, oh, you know, you're out for 1 week. Well, then you can go back. Well, what if the athlete's still having symptoms a week later? You know, we're not using that anymore. And so I've encouraged them to say, you know, go follow up with your pediatrician when you get, you know, out of the ER. Let them evaluate you. You know, if they need further evaluation, if they need to send them on to us or elsewhere, that's fine. But if they're doing well, then you guys can manage them, monitor, make sure they're resting, and get them back that way. Okay. You talked briefly in the child athlete, a longer symptom-free period. We wait a little longer. So all of this is basically saying we're more conservative in kids. The brain's still developing. We think they may take a little bit longer to get back. The axons are not as myelinated or insulated. And so we have to be a little bit more cautious, okay? Prevention, basically sportsmanship and fair play. I hear every day in my clinic, oh, well, this kid came in aggressive and took me out. No, she'd been doing that the whole game and this and that. Why are the referees not stopping that before the kid gets a concussion? And so I tell the parents, I say, you know, you need to say something. Talk to the coaches, talk to the parents. There's no reason. These are preventable injuries, some of them. Not all of them. You know, part of playing sports, but a lot of these are aggressive play and unsportsmanlike conduct. These kids get taken out and are going for the ball, especially in the girls' soccer. It's an extremely aggressive sport, and I think that that's part of the reason that the girls have it more than the boys. The headgear I get a lot. It's been shown to reduce the incidence of concussion. I saw a girl today that got her 3rd concussion while wearing headgear, and so if they want to wear it, they can, but I think that we don't have them necessarily recommend that. Helmets have been designed, like we talked about, to prevent skull fractures and brain bleeds. They don't necessarily prevent concussions. There's no concussion-proof helmet out there. The right helmet, when the parents ask, is a properly fitting helmet. It's not about what brand or whatnot. You know, we don't have much difference in them. There's been some studies that have sort of speculated, but those are dropping a helmet from a height and having it land on a piece of concrete floor. That's not showing us the rotation and the angular and rotational acceleration, which we think is more important. Mouth guards, this is called the brain pad. They speculate that keeping the jaw apart is going to keep from concussions again. That will help with dental trauma and oral trauma. It's not going to prevent concussions. If the families want to go out and spend $500 and buy a $300 helmet and a $200 mouth guard, it's fine if it makes them feel better. But I also want to tell them there's not any good evidence. And I've asked all these companies to send me studies that validate their claims, and I still haven't gotten anything from them. So in summary, immediate removal from play for any suspected concussion, and I left the word suspected. I didn't change it to believe like the law has asked us to do, because again, I think these things evolve, and when somebody comes over to me and they have just a headache, I'm going to err on the side of conservatism and caution for the most part, because I think that I'm always better doing that than the other way around. They're not allowed to go back the same day, whether it's game or practice, if they've had a concussion. Rest is the mainstay of treatment. Selective neuroimaging, if they need a CAT scan, if they're getting worse or there's something else concerning you, that's fine, but otherwise we're trying to limit the radiation and the number of scans. No return to play until completely asymptomatic at rest, with activities of daily living and with schoolwork, including tests. The progressive return to play, building them up gradually, and then now they're requiring written physician clearance prior to return to sports following concussion. So I left in here some resources for you guys. The first article is the one I talked about, the Zurich Guidelines. That's sort of it's it's expert opinion. You know, part of the problem is it's hard for us to do randomized controlled studies and say, well, this 12-year-old kid we're going to put back after day 1, and this 12-year-old kid we're going to hold him out for a week. You know, we can't do that with this type of thing when we think it may be harmful to them. And so a lot of this is expert opinion, and we're definitely becoming more conservative. A good article in a September issue of Pediatrics of 2010, sport-related concussion in children and adolescents. They basically summarized the expert opinion from the third consensus and applied it to us as pediatricians. So if you're going to read one article, I think that's probably a pretty good article. The SCAT2, there's a link you can go and get it from, so you can print it out and use it in your office. There's a PDF file there. The preventingconcussions.org is something the CDC has put together. That's for healthcare providers. So anybody that wasn't here tonight, or even you, I did it yesterday just to sort of make sure I felt like it was good. It took me about 45 minutes. It's videos, and there's experts talking, and it goes through very similar to what we're talking about. I think it's fairly well done. It's a little bit interactive and goes over sort of the latest information. So I think anybody that's, if you're wanting a refresher, or if you have anybody else in your practice that's sort of interested, I think that's a very good one. And on there's a link that says, I think, Resource Center, and it has links to all of this and a ton of other information. So if you're looking for more helpful resources and handouts, it has it on there. The CDC website, they have a whole program called Heads Up, and then there's handouts for the athletes, there's handouts for the parents, there's handouts for coaches, there's handouts for school nurses. That are done by the CDC, and I think that those are fairly good too. And the bottom one is the American Academy of Neurology. They're revising their new statement because the AAN guidelines still were using grading of concussion scales, and they've sort of said we're not doing that anymore. We just haven't come out with our new statement yet. So all of those I think are good resources. And that's it I have.
Is there a standard form that you're requiring us to sign?
No, that's a good question. So there is a UIL form that often the patients will bring to me that has room for their signature, the school signature, and then it describes sort of return to play. But there's not anywhere on there for the physician to sign. And so what I'm doing is I'm writing, you know, you can do it whether it's on a prescription pad or in your EMR or whatever you want to do. Just they need a written clearance saying that they're going. So I usually, when I'm seeing them, I'm usually saying I'm clearing them to begin their return to play protocol. And then, because if I see them and they haven't done anything, I'm not going to say, okay, return to play, return to full play, because then next they're going to say, okay, well, you can go back to the game tonight. And so the law says they should have to go through that return to play progression, but I just sort of clarify a lot of times. And sometimes, you know, depending on the numbers you're seeing, but a lot of times I'll tell the patients, okay, I'm going to clear you to return all the way through stage 3 or 4, which is non-contact. I'm going to allow you to do full practice where you're up there after, you know, 4 or 5 days and really getting in conditioning and weightlifting and running and jumping and cutting and using the balls with nobody hitting you, nobody coming, you know, no scrimmaging. You call me after you've done that without any symptoms, then I'll clear you back to full contact practice. And until then, so that way it gives me a little bit of a leeway that I make sure that they're not sort of playing through. And you know, whether that helps or not, but I don't always make them come back and see me again. Sometimes I do, especially the ones if they've had prolonged recovery or if I don't trust them or something else, I make them come back and sort of go through things.
So you don't
but
see them or even have contact with them at each of those 5 stages or whatever?
Depends on the situation, but no, I think that would be, you know, the ideal situation is a lot of these schools have athletic trainers. You know, when you're talking about the middle schools and the elementary schools, it's different. You know, they don't. And so then I find a responsible parent and make them become the athletic trainer, because I find that usually after I've educated them, the parents are a little bit more involved in caring them than the coaches are going to be. Whereas the athletic trainers a lot of times at the school are pretty good about pushing them through it, and so you can sort of let them progress through things. But you know, if it's an 8-year-old and the parents don't really have a clue what's going on, then I'm probably not going to just let them go on, you know, on their own.
And in any event, you see them back before full return to play?
In general, I probably see patients, I would say an average of about 3 times. I see them, you know, relatively soon after their injury if they've been sent to us. I see them, you know, at some point when they're recovering, and you know, and then I want to see them. I won't clear them until they're completely back to normal in my office. And so, and you know, their exam is normal, their balance is normal, they're doing fine on all their neurocognitive testing, they're having no symptoms at rest, no symptoms at school, everything else. At that point, then I will clear them to start back to physical activity. And so sometimes I feel like nothing's going to change in terms of my exam if it's already completely normal. It's more about what they're telling me. And so if I can manage that without having to bring them back, then sometimes I'll do that. But again, it's a completely individualized case. But I may have already seen them 3 times by that point. So it's not uncommon. But again, I think it's important to realize a lot of times it may be 3 to 4 weeks. So if I see somebody and they're 3 or 4 days out for their concussion, I'm not going to see them back the next week right away. Part of it's just my capacity. I don't have room to, but if I need to, I can see them right back. But most of them, I'll say, I'll see you in 2 weeks. You know, there's nothing I'm going to do differently unless you're getting worse. If you're getting worse, I need to know that much sooner. Come back and see me. But otherwise, you need to rest. You need to do this. I'll write a letter to the school and get them through things. And I think that they will get better. And then they come back. And a lot of times they're getting close, but they may be 85% better and still not quite there. And I say, okay, you need another week or so. We'll see you back again at that point. But, you know, they let you get through it.
School district,
Mm-hmm.
I've had some kids say that they put all of them through this computer,
Mm-hmm.
neuropsych kind of that 30-minute thing.
Mm-hmm.
And then after we return them, then they go back and repeat that. Schools don't repeat it until after
Mm-hmm.
they've been cleared. Is that part of the law, or is that?
No, it's a good question. So in the Dallas area, there are a lot of the school districts are using Impact as one of the more common ones here. And so it's hard because, you know, if there's nobody there to interpret the test, you know, it doesn't do you much good. But I think that some of the schools are using it as a second sort of stop. And for example, I had a kid that was cleared by the pediatrician, and then the athletic trainer did their computer testing and called me and said, hey, I don't think the kid should be cleared, and I'm worried because now I have the doc and the parents think that they should go back, but they're, you know, this is what the results are. And I said, okay, send them over, we'll take a look at them and talk, and they were right. So they're using it sort of as a catch guard. But again, I think that that child was still having symptoms when you really got down to it and asked them. So did that change? Would that have changed my management? No. I think that if you're really asking me, you just got to tell the kids and really be honest and say, look, you got to be honest with us, and this is why we're worried. And I find that they are more forthcoming once they understand the reality of it. It's not just about, you know, because they know until they tell you they're not having any symptoms, they don't get to go back. And so if they want to lie to you, then they can. But I think that that's why it's important to educate them about why we're asking them. So if the schools are using the test, but who's interpreting the test? The athletic trainers. You know, it's a neuropsychological test.
That's right. And you did mention, so when do you think we need to send them to you?
That's a good question. I didn't go into that. So I would say, prolonged recovery. Okay, if it's been more than 2 weeks or so and you feel like they're not making progress that you like, any very severe or concerning symptoms to you, a lot of these kids will look really bad initially, but if you give them a few days rest, they're starting to get better. That's going to be fine. If they have a lot of comorbidities or other things, if there's, you know, mom has migraines and the kid has a little bit of ADHD and there's other things going on, if they have multiple concussions, if this is their second or third concussion, anything else that's sort of concerning to you, I think that's reasonable. I would like to be able to see all of these, but I'll be honest with you, I've probably been seeing about 5 or 6 per day in my clinic, and we're just overwhelmed with space. And so if you guys can manage them, most of them, in the first couple of weeks, and if things are not going well, then call us in, as opposed to the ER sending us every kid that's been sending the children's ER with a concussion. So I've been giving talks to our ER and saying, hey, so let them see their PCP. Send them, because if the ER docs send them home with the same recommendations I just gave you, hopefully they're already going to be doing better by the time they see you in a couple of days. Maybe they didn't go to school for 2 days and then they see you, and now they're ready to go back for a half day and get back into things. So there's very little I'm going to do in most of them differently than what I just told you tonight, the first 3 or 4 weeks. Other questions? Yes, sir.
What number is concerning to you regarding the SCAT scoring system, or do you use that as a comparison tool between visits?
Yes. I use it more to sort of monitor their improvement, because depending on, for example, symptom scores and that kind of thing, I like to use it to reassure families. I think that making them feel good is very helpful. And for example, I had one mom that was calling us every day and was very distraught because her child was having headaches and blurry vision. And so I actually sent her home with the symptom scale, and I said, I want you to fill this out every day. I said, actually, not you, I want your child to fill this out every day. And they brought it back in at their next visit, and I went through it like a flip book, like a cartoon, and sort of showed them all of that check marks were moving down. And even though he was still having symptoms, they had all gone from 6s down to 2s. And I think that, and she sort of, she was very worried. She wanted an MRI and this and that. I said, your child's improving. He just needs some time. And when you're watching him every hour, it's hard to see that improvement. But when we look at it as a big picture, he's overall getting better. So that's how I used it to show her that. But I think that also helps when I can show them, look, your child's balance last time was terrible. They scored, 19 out of 30. This time they scored a 23. Well, it's still not back to normal, but they're getting better. So that's how I look at it a lot of times. Yes, ma'am.
And aside from concussion,
It's a good question. It's been busy with the new law. I think I saw about 70 concussion visits in 2010. Before October even came around, we'd already seen over 200 this year. So, not including October and November, which have been our two busiest months. So it's been difficult, and we're mostly up at legacy. But we see most musculoskeletal injuries, so acute injuries, knees, shoulders, ankles, overuse injuries, Osgood Schlatter, growth plate injuries. Anything else that's going on, we talk to athletes. So, and again, I'm a pediatrician first, so we deal with some of the other medical issues that are related to sports, some of the sports psychology stuff. If they have questions about nutrition or supplements, all those different types of things. Yes, sir. It's a good question. So retirement from contact sports is a touchy issue. We used to sort of say 3. We thought 3 was the magic number. If you've had 3 concussions, you're done. We don't know really if there's a magic number, but what we look at is how long it takes them to recover. So for example, if they've had 1 concussion, it took them 8 months to get back to normal, well, then maybe that person should never go back to playing soccer or football and miss another 8 months of a school year. That's an entire year of their life. Whereas if somebody has had 2 or 3 and it took them just a couple of days each time and they were back fine, doing very well and healed very quickly, so it's number, it's how long it takes them to recover, it's the threshold. So if somebody took a really bad hit the first time, took a little bit of a hit the second time, and the third time they didn't take hardly anything, nobody even realized they got hit and they got a concussion, well, that brain is showing us that it's more and more sensitive and unable. And we look at comorbidities. If there's any sort of abnormality on imaging, I had a young man that he had taken a fall off his skateboard and was out for several months, and then he has sort of scarring on his MRI essentially. And so I told him I don't think he should ever play football again because he's at increased risk. So it's a complex answer. I tend to start talking about retirement, the injury before the time I'm ready to retire them. So if they've had 2, they're having 3, then I'm starting to say, look, you need to play smarter. You need to not be that girl going out there and playing aggressive. You need to keep your head off the turf, keep your head away from other people. Because if you get another one, we may have to start talking about, no matter what career you're going to choose, you need to use your brain. Even if that's a professional athlete. But if you can't keep your brain healthy, you're not going to be able to make it there. So when I'm seeing 12-year-olds that have had 2 or 3 concussions, I'm already going down that road with the family and saying, look, we need to really protect them and be conservative here. It's not an easy discussion to have, though. We're happy to help you with that. Other questions? Thank you guys for your time. I will say one more thing is, please feel free to use us as a resource. We're Children's, we're the academic, we have residents with us all the time, but I think that you guys don't feel like you're out there alone. Feel free to give me a call. If you have a patient that you have a question about, even if you don't, should you send it to me or should you not, or if you just say, hey, I just want to run this by you, I'm happy to do that. It doesn't have to be a concussion. Anything sports medicine, pick up the phone and call us. So one of my partners, we should be happy to talk to you guys. I think that we should be there as a resource for you guys in the community. All right. Thanks for your time.